Hi, my name's Hegazi. I'm a doctor. I've been working here at the courtyard since 2008. I'm going to talk to you today about HIV transmission, so thank you very much for coming. So what I'm planning to talk about today is how HIV is transmitted, how HIV is not transmitted. A very common question I get asked by my patients and some of their partners is, can I pass on HIV if my viral load is undetectable? And at the end I'll give you some pointers as to where you can find out some more information if you're interested or have any additional questions, but we will have some time at the end for questions. So I'm going to start with some basic facts about HIV. HIV can only be transmitted through 5 bodily fluids. So for example, if it's not on that list of fluids, you can't transmit HIV, you can't transmit it from saliva or any other bodily fluid. And those 5 fluids are blood, vaginal fluid, semen, rectal fluid and breast milk. So blood is from sharing needles and blood transfusion. Anal sex and semen is when HIV is transmitted by anal sex. Vaginal sex is when from semen and vaginal fluid mixing, and mother-to-child transmission is from vaginal fluid or from breast milk. These are some of the ways HIV are not transmitted. It may seem very basic, but I do still see people panicking, saying, I've just drunk, my 2-year-old daughter's just drunk from my glass, or I've just kissed someone. So HIV is not transmitted by sneezing, hugging, cutlery, sharing glasses, toothbrushes, toilets, etc., etc. Another fact to remember is HIV only infects humans. So next week we've got Dr. Hay coming to talk to us about clinical trials. And whilst that's a good thing in some ways, it also means that we can't do experiments in animals with HIV. We can't infect lab rats with HIV, for example, and test and do experiments on the virus that way. And you'll hear me throughout the talk referring to viral load a lot. So just a reminder of what viral load is, but hopefully most of you came to Dr. Packer-Nathan's talk and Helen Webb's talk, and they will have explained this. So when we say viral load, all that means is we literally take 1 ml of blood and count the number of virus particles in 1 ml of blood, and that's all it is. So if the viral load is 10,000 copies per ml, that means in each ml of blood there are 10,000 virus particles, and we would actually consider that a low viral load. The virus is so small that actually that's considered a low viral load. If there are 100,000 copies per ml or greater, we'd consider that a high viral load, and you'll hear me referring throughout the talk to high, low and undetectable viral loads. And in most people who are on treatment, the viral load will be undetectable. And when we say undetectable, it's currently less than 40 copies in each ml of blood. So moving on to what the title of today's talk is about, is how is HIV transmitted? So I'm going to start with mother-to-child transmission. We don't see a lot of this in the UK, but it's still a very important problem across the world. So in 2013, which is the latest data we have, 240,000 children were infected with HIV. And there are still over 3 million children under 14 living with HIV. Almost all of them are in sub-Saharan Africa, and almost all of them were infected vertically. So I'm going to do a thought experiment. So I'm going to take 100 pregnant HIV-positive women. All of them have HIV, all of them are pregnant, and I'm going to ask the audience the question, how many of those babies will be born with HIV?
100.
Any lower?
50.
50. So let's see who's closest to the answer. So if we do nothing to those 100 women, 8% of those babies will be infected during pregnancy. So while they're in the womb, they will become infected with the virus. And actually the most dangerous time for the baby is while they're passing through the birth canal during delivery. So about 17% of babies will be infected during delivery. And another 5% will be infected from breastfeeding. So roughly a third of those babies will be born with HIV if we do nothing at all to prevent transmission. And the reason we have quite good data about this is in the bad old days, before we had good treatment for HIV, this is what happened when women were pregnant with HIV. There wasn't very much we could do. And so we could observe how many babies were born with HIV. Now, luckily, we don't do nothing. Many of you will know we have a mother and baby clinic here, and many women with HIV have babies. In the UK and Ireland, there are about 1,500 pregnancies every year. And the actual HIV transmission rate is a lot less than what we saw on the previous slide. So it's about 5 in 1,000, and in mothers whose viral load is undetectable, it's about 9 in 10,000. So that's very low. And some of the things we can do to try and reduce transmission are, if you don't know you have HIV, you can't do anything about it. So the most important thing to do for a pregnant woman is to tell her she has HIV so that she can take up treatment and stop the baby getting infected. And we've done very well in the UK now. Over 97% of women will agree to have a test when they're pregnant, which is fantastic. We give the mother antiretroviral therapy, and the obstetricians will take precautions during delivery and make sure the baby isn't stuck in the birth canal for a very long period of time, for example. We also advise that breastfeeding is avoided, and we'll give the baby a 1-month course of PEP after they're born. And with all of those things, it's now extremely rare to see any babies born with HIV whose mother knows she has HIV before they're born and takes up all these interventions. So that's a success story really for HIV. So I'm going to go on and talk about sexual transmission, which is undoubtedly the most important route by which HIV is transmitted across the world, and certainly in the UK. So I'm going to do another experiment, which this time slightly different, and I'm going to ask people from the audience. This is a man, and this is 100 women, and this man is going to have sex with each one of those 100 women. And I'm going to ask for an answer how many of those 100 women are going to get pregnant. And I think most of you will want to know more. Who are these 100 women? Are they all aged 80? Are they all aged 16? Are they all infertile? Are they all fertile? Whereabouts in their cycle are they? And you won't be able to give me a straight answer. For example, 8 women will be pregnant, because it's going to depend on a lot of factors. And if I go on to talk about HIV using that same analogy, this is 100 women, and this man has HIV, and he has sex with each of those 100 women. How many of them will get HIV? I think the answer to that question will be exactly the same as the answer to how many will get pregnant, in that it completely depends on a lot of factors. So what are these factors that HIV transmission depends on? So I'm going to ask people to name the top 3. Number 1 is viral load. Number 2 is viral load. And number 3 is viral load. So it's undoubtedly the most important factor that determines whether or not someone's going to get HIV from sex. If you have a high viral load, you're very likely to transmit HIV. If you have an undetectable viral load, you're very unlikely to transmit HIV. And we'll talk a bit more about undetectable viral loads later on. But viral load is the most important factor in determining HIV transmission. Just a reminder, Dr. Pakinathan mentioned this in his talk, when people are likely to have a high viral load. So there's 2 times when people are likely to have a viral load are A, around the time of seroconversion, so very early on in the illness when they've just recently become infected, and often people don't know that they have HIV around that time. They might have some symptoms, some vague symptoms like a flu-like illness, but then usually when people are seroconverting, they have a very high viral load, and that's when a lot of transmissions take place. And the other time is in people who have not been on treatment for many, many years, and then they become very unwell. Often towards that time, their viral load goes up as well, with illnesses, for example, TB, or when they have an opportunistic infection. So those are 2 times when transmission is most likely to take place. So what else is important after viral load? There are some other factors. Condoms are important. It's very difficult to measure how good condoms are at preventing HIV. The biggest problem with condoms is that people don't use them. And the second biggest problem is that when people use them, they use them incorrectly. For example, they put them on too late, or they use them inconsistently. And most condom accidents happen because people put them on incorrectly or because of poor technique, and most condom failure is due to that. So for those of you who come to our clinic, if you would like a refresher on how to use a condom, the best thing to do is to speak to one of our health advisors, because they can do a demonstration and update you and on how to use it correctly. It's hard to measure how good condoms are. Roughly 80% protection against HIV, but we think the protection is greater if you use them 100% of the time, perfectly. So it's worth investing in seeing a health advisor, especially if you're using them for contraception. Another factor is type of sex. So some types of sex are very, very low risk for transmitting HIV. and some types of sex are higher risk of transmitting HIV. For example, oral sex is very low risk of transmitting HIV. It's extremely rare for HIV to be transmitted by oral sex. Vaginal sex, particularly for men, is less risky, and it's slightly more risky for women. Anal sex is more risky, and that's because the lining of the anus is usually very fragile and it gets broken easily and it has a tendency to bleed. So there's more blood likely to transmit. There's also probably a slightly higher viral load in the anus. And passive anal sex has a higher risk of transmission than active anal sex. And probably the highest risk in terms of sexual transmission is sex that goes on for a very long time, for example, chemsex or sex on drugs, or sex that involves a lot of trauma like fisting, where there's often blood or breaks in the rectal mucosa. Which makes it much easier for the virus to move from one person to another. PEP, most of you will be familiar with PEP. So again, PEP we think reduces, it's another thing that's hard to measure in real life experiments, we think it reduces the risk of HIV transmission by about 80%, but the sooner PEP is started the better. So if you're going to take PEP, or if you're going to advise a partner to take PEP, it should really be done as soon as possible, and the longer you wait after taking it, it won't work at all after 72 hours, but the sooner you take it, the higher the risk of the higher the protective effect will be. PrEP, this is a relatively hot topic at the moment. So PrEP is like PEP, but you take it before exposure instead of after exposure, and there are different ways you can take it. It does protect against HIV, about 86% in selected people. It's not available at the moment on the NHS, and I would say watch this space. It may well be available in future, but for the moment, if you want to protect yourself against HIV, you'll have to rely on other tools. Male circumcision. This protects heterosexual men, but no real protective effect has been demonstrated in gay men. And we found out about this in around 2007. There were some very big trials that went on in 3 countries in sub-Saharan Africa, so South Africa and Tanzania and Uganda, I think. And they took lots of men and they randomised them, they put them into 2 groups. So next week you'll hear from Dr. Hay about randomised control trials. And they circumcised half of them. They were all men who wanted to be circumcised. They gave them all condoms and told them about, advised them to have safe sex. And they circumcised half of them, and the other half agreed to be circumcised at a later date. And they found that circumcision was around 60% protective against HIV. So it's not something that we would use here in the UK. It's not something that would be very useful for us here in the UK because we have better tools. And it doesn't protect women, unfortunately, just the men. But in some countries, the World Health Organization is rolling out circumcision now as a way of reducing the risk of HIV. Sexually transmitted infections. So if you have a sexually transmitted infection, you're more likely to pass on HIV and you're more likely to pick up HIV. If you have ulcers, there's more exposed skin, so the virus can pass more easily from person to person. But also, even if you have infections that don't have symptoms, for example, syphilis, that will increase the amount of HIV virus, the HIV viral load in your genitals, and means it's more likely to pass on or pick up HIV. So it's important for people with HIV and all their partners to get regularly checked for sexually transmitted infections and get them screened and get them treated. Genetic factors. There's a lot we don't know about the genetics of HIV. We do know that some people are more or less likely to catch HIV depending on genes. And there are some genes that are more common in Caucasians. There's a gene, for example, that there's a very small proportion of people, around 1% of Caucasians, that are completely immune to HIV. There's a gene that means you don't have one of the receptors in your cell that the HIV virus needs to get into the cell. So those people are completely immune. There's another gene, for example, that's related to malaria. It protects from malaria, but it means you're more likely to get HIV. But that's sort of, and we also know that immunity can come and go with time. So sometimes you can be immune and then years later the immunity can go. So that's still something that a lot of studies are going on with, but it's certainly important and comes into it. And then I think good old-fashioned luck and chance. There's always going to be that 1 in 1,000 or 1 in 10,000, and there's always going to be people who will be lucky, and there are probably that factors in a lot of things we don't know about. In real life, the answer to the first question is how many will get HIV. The answer is going to be, it's going to depend on all sorts of factors. It's going to depend on your gender, your genetics, the type of sex you had, the viral load, the strain of the virus, the duration of the sex, whether the person is circumcised, and a bit of good old-fashioned luck as well. So just going to do some studies, just very briefly talk about a couple of important studies from the real world on HIV transmission. This is a very famous study that reported its results in the summer of this year. It's called the HPTN 052 study. And they took 1,700 couples where one partner was positive and one partner was negative in 9 countries. About over half of them were in sub-Saharan Africa. And most of these couples were heterosexual couples. And they followed them up over 10 years, which is a very long time to follow up these couples. And they started half of the people, this was before we start, now we recommend treatment at any CD4 count, but back then we recommended that people wait till their CD4 count approaches 350. So they started, there was a treatment group and a group that decided to wait, and there were people who decided not to take treatment as well. And in people who were on treatment, they only saw 8 transmissions in the entire 10 years to the other partner. There were other transmissions, but they were able to type the virus and found that that virus had come from outside the relationship. And 4 of those transmissions were soon after people had started antiretroviral therapy, so early on, and 4 before their viral load was undetectable, and 4 of the other 4 were in people who started on treatment and then had stopped taking their treatment and their viral load had come up again or rebounded. And they didn't see any HIV transmissions at all from HIV-positive partners who were on antiretroviral therapy who had an undetectable viral load. The thing to note about this study is they were all given condoms and counselling. However, we do have a comparison group of people who were not on treatment, and we did see a lot of transmissions in the other group. So that's all very well, but it doesn't answer not very helpful for gay couples, particularly as we said before, anal sex is quite different, and also it doesn't really answer the question. We can't guarantee 100% how many of them were using condoms and how much of a role condoms had to play in that effect. So this is a different study, and this study is still ongoing. It's only been going on for 2 years, and we're waiting for more information, but these are some initial results. This is a study of about 1,000 serodiscordant couples. So those are couples where one partner is positive and one partner is negative. What's different about this study is these are couples that are choosing not to use condoms for sex. So they're choosing to have sex without condoms. And all the positive partners were undetectable. So if your viral load rose above, they were all on treatment and undetectable for over 6 months. If your viral load came up over 200, you were actually kicked out of the study. So it really is designed to look at the question, what is the risk of transmission if you have an undetectable viral load and you don't use a condom? And they said no PEP or PrEP. So far they've seen no transmissions at all. They've seen some transmissions from outside the relationships, but no linked transmissions. However, there are only very small numbers of couples who are choosing to have passive anal sex with ejaculation. So they just need more follow-up to get a better estimate of what the real risk is, and the study's still recruiting and studying these couples, and hopefully we should hear some more information, but it will be very interesting to get a better estimate. But what we can say based on these results over 2 years is whatever the final results, the risk of HIV transmission with an undetectable viral load is very, very low. So what about me? How do all these facts and figures and studies affect the actual patient? I think most of us will have seen this in the news yesterday, and I think most of us will agree that the coverage of Charlie Sheen's HIV diagnosis was probably quite different than it would have been if he had had another medical condition such as a heart condition or diabetes or high blood pressure. And I think sometimes people medically say HIV is just a chronic medical condition, just like any other medical condition. And whilst that might be partly true medically, there's still a lot of stigma, and I think this is a very good illustration. I don't think Charlie Sheen would have paid millions to blackmailers to keep a dodgy heart valve secret. And I think when people come to clinic, a lot of the time they're very focused on their viral load, contraception, condoms, PrEP and the HIV. And sexual well-being is about a lot more than that for the patients we see. And it's very important to look at all the other factors such as confidence, self-esteem, pleasure, healthy relationships, and to take a holistic view rather than just focusing on viral load and transmission. So just to point you in the direction of some other seminars that we have coming up. So in January we've got, because these things are important, I haven't covered those issues and I've talked about HIV transmission today in quite a sort of more in the mechanics and how the virus is. And viral in terms of viral load and numbers and facts and figures, but we do appreciate here at the clinic that these issues are important, and we've got some sessions planned in future dates. So one about sexual pleasure, one about happiness and emotional well-being and telling other people. So I'd encourage you really to come to those sessions if you can, because that's obviously a much bigger part of HIV transmission than just the virus. If you want to keep up to date with studies and resources, NAM have some excellent resources, and they will, patient resources, as do iBase, and they will keep you up to date with the latest studies when research is published that's relevant. And also use your clinic as a resource. We have a fantastic team of pharmacists, health advisors, doctors, nurses, so if you have any questions or concerns, please raise them with the team. And thank you very much. We'll have about 20 minutes for questions.